welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Kwasi Kwaadu. Thanks for joining me.
Jeff, thank you for having me, man.
Absolutely. We're kicking off season 2 with some big guests, so I appreciate you hopping on, spending some time with us, and giving us the lowdown.
I thought you said big guest, so you got me on.
You're a big guest to me.
All right, on. I appreciate the love.
Yeah, so you're a professor, associate professor there at Temple University School of Podiatry. You did your residency at ARIA in Philly, and then you did Dr. Fleming's fellowship also in Philly. So you've kind of spent quite a bit of time there in Philadelphia. So talk about what it's like working at the school and teaching the up-and-coming students there.
Man, I think, I'm a little bit intense. I actually dialed it back significantly over the course of my career.
Did you make too many people cry?
Exactly. and then I'm honestly just kind of being introspective, right? I mean, if the end goal is to kind of feed the product, if the product is scared of you, I mean, you ain't really helping yourself out. So, just maturation primarily. So, I mean, I think I like to probably over the course of my career, what I like to do with the students primarily is to kind of get them to kind of think critically, right? I think sometimes, particularly when we're interacting with students and they look up to us, sometimes there's this kind of barrier between our interaction and them, and they kind of get in the role where they think, they just gather, particularly in the clinic setting, they gather information, give to you for you to give them answers. But, ultimately what you're trying to do is to develop to be a physician. So, I have a different way of kind of interacting with students in the clinical realm where I ask them to kind of present with their assessment. You go in there, you talk to the patient, you examine them, all that type of stuff. Tell me what you think is going on, right? That's where I want you to start. Because traditionally we start with HPI, PMH, and all that stuff. I got you, right? Just tell me what you think is going on. And then after that, then I want you to go back and tell me all the information that led you to arrive at that conclusion. Mm-hmm. So with me, I think I try to challenge them. I force them to think. With the way EMR is now, you type KEF and everything with Keflex kind of populates, right? Like you turn your brain off. And
it does have to work for you.
It's harmful, right? So I have them handwrite your prescription, and then once they start doing that, they can immediately start to kind of really see, I don't really understand this quite as well. So my thing is to kind of really just get them out of the rigmarole or kind of the routine, and maybe just kind of get them to look at things from a more mature perspective, like from where we are, right? I kind of want them to kind of advance to that level because that's where they're going to be. It's like, how people, and I'm sorry if I'm dominating this conversation, but how people have kids and they talk to kids and they go, the baby talk, right? Goo, goo, ga, 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 blah, 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 right?
Yeah.
And my thought process is always, that they're going to speak like that for such a small time period, but for the rest of their lives, this is how they're going to speak. So start that early. I don't understand the point of kind of delaying. So that's kind of what I do, my teaching style, kind of teaching at the school, interacting with students. That's how things are with me.
Yeah. And I think sometimes it's, if as long as it comes from a good place, which I know with you, it does, as long as it's coming from a good place, if you're hard on them, that's only going to make them better. My wife teaches at the school and we have some faculty there and some of them are hard on the students, and that feels intimidating. That feels difficult. But if the hardest situation you've ever been in is at the school, then residency and externships and all that stuff is going to feel a whole lot easier than it may have otherwise been if you were coddling them when they're there at the school. So I think that comes from a good place, and you're essentially making them better is what you're doing. So talk about your kind of regular routine day there in the clinic. You're pumping through patients, but then you have to stop and try to teach while you're doing that. That's hard to do because I have students that that come with me as well. So I know what that's like, trying to teach and practice at the same time.
Yeah, I mean, I think you have to be intentional, right? I mean, to your point, it is hard, but it has to be kind of on the forefront of your mind because, you can find any excuse not to do it. All right. But you have to kind of really think about it. I know when I first started, I was terrible with student names. And in fact, some of our residents used to even make fun of me and say that I even call the women Bud right? Or buddy, right? I was so terrible.
Yeah.
And so I make it a point to just, anytime I'm interacting with anyone, I say their name in conversation, and it helps me out. So similarly with kind of making sure that you're taking time to teach, because again, everyone doesn't do it. You have to kind of be intentional and just kind of find the small opportunities. It doesn't have to be anything grand, right? Even small lessons where before I go in the room, I'll say to a student, listen to what I say to the patient, listen to how I interact with them, because, this isn't something you'll learn in the classroom. You'll learn about the academic and everything, but, telling someone bad news, or telling someone, maybe something went wrong with the surgery. Those are important things that you'll never get until you get it. And so, just trying to be intentional about teaching in any opportunity, I think is how I kind of proceed.
Yeah, absolutely. So, you're originally from Ghana.
Yes, sir.
We've listened to you on Dean's Chat, which is a fantastic podcast. If anyone doesn't listen to Dean's Chat, check it out. You and I have both been guests on Dean's Chat, so shout out to Dr. Jensen. But you kind of talked through your journey. But for anyone who hasn't heard that episode, why don't you talk through kind of your journey of starting there and ending up here, and how you found medicine, specifically podiatry?
Yeah, I mean, I came. I'm Ghanaian, but I was actually originally born in Nigeria, and I was there for, I don't remember it,
Mm-hmm.
but my dad was there teaching with our family, and then we moved back to. He was a history professor, and we moved back to Ghana, and we were there for about 7 or 8 years. And my mother, her family side had breast cancer. And so she was having some issues, and had kind of exhausted care in Ghana, and kind of the next step was to come to the U.S. for care. So that's how she came here. We went to Zimbabwe, my brother, my sister, my father, and we were there while my dad again was teaching. My siblings, who are about 10 years older than I am, 9 and 10 years respectively, um, were in college there. And then ultimately, we came to the States and stayed with my mother and my dad. His preference was to kind of be back home in the motherland. I don't blame him.
Mm-hmm.
So he went back to kind of do his thing. And so, throughout the course of education, kind of learning American culture and all these things, and living in kind of Southeast Pennsylvania, graduating from Chester High School, same place that Jameer Nelson attended.
Mm-hmm.
If you follow college sports at all, way back when. And then ultimately kind of arrived at Temple as an undergrad. Throughout kind of the latter part, my uncle, and when I say uncle, really kind of a close family friend. In Ghanaian culture, we're all kind of family,
Mm-hmm.
particularly in a foreign country. So he was a podiatrist, and but certainly not to in a realm that you would kind of think of kind of the current state of affairs when you think of podiatry. It was kind of old school, like traditional in office, like laundromats attached to the office deal. You know what I mean? Doing
Yeah.
bunions right in the office, just that type of
Yeah.
stuff. So
You can
uh,
get a load done while you see the podiatrist.
exactly. You can you can watch the OR scrubs as you're doing bunions right next door.
There you go.
So no, that was real, right? And so I was introduced to that through him, and ultimately kind of did one of the internships at Temple, and then kind of saw, like, at the time, like, Kieran Mann up close, and seeing him run a massive kind of pediatric clinic up at Shriners at Temple. So I got a chance to kind of really start to kind of gradually see what podiatry was, or where I thought my role fit, and it's been phenomenal. I just find myself incredibly fortunate to be in this realm, because for me, it just, as hard as it is, and as much as we put in, it doesn't feel like work. You know what I mean? And that's just kind of a real benefit and a blessing.
That's a good sign, right? I mean, it's kind of cliche to say, if you love what you do, you don't work a day in your life. But it obviously it's cliche for a reason, because it's true. And I agree with you. There are days that are more difficult than others, but when you enjoy what you do, and I've said this before, I think working with the students kind of keeps things fresh, because they come in with a new mindset and they're open to learning, and everything feels new, versus it's easy to get stuck in a rut and kind of just go through the motions when you're out by yourself. But having that new, fresh perspective, and they ask me questions that I have no idea the answer to. You'd think I know. I've been doing this on my own for almost 10 years out of residency. They'll ask me, I'm like, I don't know. You got to go back to, I don't know, look it up. I haven't thought about that in 10 years, right? But so they keep that new, fresh perspective that keeps me thinking, yeah, that's a good thought. Why do I do that? Okay, yeah, let me think about that and make sure that the reason I'm doing that is not just because I fell into the same patterns, but because there's a reason behind it. So I think you're blessed from that standpoint to be involved with the students, although it does come with some headaches. Not all students are created equal. There are some headaches that come along with teaching and being involved with that. And I've noticed maybe a generational shift in terms of how they interact with elders and how they interact with each other. Obviously, they've grown up in a more social media dominated culture or generation. So what are the difficult things that come with working with students of maybe the next generation below you and I?
Man, so I'll cite a couple examples. So today we were talking about this idea that there's some kind of discussions again about even reducing the duty hour restrictions. I don't know if you've heard of this at all. So it's about 80 hours a week, and that's kind of bimodal, right? Like things can kind of fluctuate, what have you.
You're talking about in residency.
In residency, yes, sir. Yeah. And our director was saying, was kind of, a little bit annoyed about it, kind of sheepishly joking, and said, you know, mentioned that, we didn't have duty hour restrictions. And one of the students was just baffledly shocked at the idea that, we trained without that. And, it was kind of funny, like the naivete and kind of, behind the statement. Another thing I think I've noticed kind of with students too is, again, you mentioned kind of interaction with elders, right? So when I first started at Temple, people were terrified of me. I'm just, this guy.
Yeah.
And, part of it was kind of my personality. I was hardworking, grinding. I'm doing this. I'm trying to impress. So, I intimidated perhaps without necessarily intentionally trying to, but I did anyway. And so I recall, you know, students now I'll run into them in conferences and they'll tell me how they were so scared that they didn't even want to ask me whether they could go to lunch after like their morning clinic session, which I wasn't, that wasn't on my mind whatsoever. Like, oh, I'm gonna be so terrifying. They want to ask, it's not even on my mind. Right. And now, fast forward, 10, 11 years, the students finish and I turn around and like, they're gone. Right?
Yeah.
And it's not anything about, oh, I want you to respectfully tell me, but like, yo, I'm responsible for you, right? Like you're in clinic with me. God forbid, like say like, oh my goodness, like the building starts to collapse, right? And I'm like, oh my God, I don't know where the student is. They have to be in the building. I got to run in there, go help him. And, like just that communication, that aspect of it is just, it's unusual to me. But to your point, that is something that I've noticed. And again, I don't think it's intentional. It's not malicious. It's something that, they do. There's kind of an independence that people have that, that independence somehow doesn't, I think, translates to kind of practicality.
Yeah.
And let's just talk. Like if we have beef, we have issues, like let's not text about it. Know what I mean?
Yeah.
Let's verbally, like I want you to hear my emotions. I want to see your face. Like let's, and I think those things are and I think, perhaps it is society, but those things I've noticed for me like seem unusual, and I'm kind of feeling like, am I an old guy? Like legit now?
We're getting there.
Yeah.
I don't feel it, but we're getting there. Because there is a generational shift. I always joke that each generation is weaker than the generation before it. And you know how I know that's true is because the generation before us fought in the Korean War, and before that was World War II and World War I. And I would not last 5 seconds doing any of that stuff that those guys and gals were. Great Depression, like, nope, I wouldn't last 5 seconds. That's how I know every generation is weaker than the one that came before it. So, unfortunately, we're dealing with, these things, but for the most part, they're good. I don't want to bash them too much, but there are some differences there that I have noticed that make it kind of difficult in terms of respecting, sir, yes, sir, no, sir, calling you first name versus doctor, whatever. Yeah, it's different.
Jeff,
What?
you don't give yourself enough credit. I think if you lived in that era, I think you'd be fine.
Well, it would be the expectation is that you would find a way, and you'd be instilled with more grit. You'd be instilled with more, you know, generational hardship that just comes by nature. Now I wake up to my, music of choice with the slow light that comes on in the warm bed, and my furnace raises the temperature as I wake up, and my coffee pot starts brewing itself, and you're just like,
Yeah.
we got too cushy along the way. We need to get some more grit back here somehow. I don't know how to solve that though. What?
You gotta come practice in North Philly, and
Okay.
you'll have a perfect balance of all the good stuff in the suburb, and then you're gonna come to Philly and
That's what I need.
duck
I,
gunshots.
I need Philly. I need like a week of Philly. I don't need. Then I'll be like, okay, yeah, I'm back. I'm back. What are your favorite things to teach? What are you passionate about? What really gets you going when a student asks a question, you're like, yes, here I go. I'm about to give you all my knowledge on this.
Man, trauma gets me going. Trauma does it for me because for a long time I didn't understand it until it finally clicked. And I mean, I owe everything to Justin. I mean, the way he was able to, and honestly, to the point, I think a lot of that for me kind of started when I went to DeKalb as a student, October 2008. I remember it very vividly. Again, kind of in the same way that, my uncle was this, and then I met Kieran Mann, right? It was just like such a significant leap in what I was used to. When I went to Atlanta, I saw just a swath of just excellence. You know what I mean? And that startled me. And but it also kind of gave me the perspective that there's something greater, right, than what you've been told. And so when I came under Fleming's guidance, there's a lot of things I didn't understand about trauma, and we were fortunate to kind of be in a scenario where we were the only there was no orthopedic foot and ankle service where we were at the time. So I mean, we were like plating mid-shaft tibial fractures and doing like incredible stuff. But we got to kind of learn about trauma, like not just academically, but just kind of really in a granular way that helped me understand trauma in a better way, that helps me teach students in a better way. For example, for a long time, and I say this all the time in literally everything, and I say this example very specifically. For a long time, when I learned about trauma, the concept of syndesmotic stabilization was uttered, right, as kind of that tertiary thing. You got to make sure that you check once the lateral and medial restraints, osseous restraints are addressed. But it wasn't until later, did I understand that when people talk about syndesmotic instability, they're really talking about the deltoid, right? That's really ultimately what the conversation is about, because if the deltoid is intact, who cares about your syndesmosis? You have a high ankle sprain. The ankle isn't unstable in theory. Mm-hmm. But when experts talk about it, they, syndesmosis, and as such, when students think about the concept, the idea of the deltoid, which is, the most important thing, is not even a consideration. And again, it didn't occur to me until later that syndesmotic stabilization is an indirect way of addressing the deltoid, because at the time, the technology didn't allow us to kind of really effectively address the deltoid. A normal medial gutter is 2 to 4 millimeters. What kind of suture needle are you put in there, right? Mm-hmm. Those little things that I think as experts, when we're communicating with novices, I think we can do a better job of, because we don't realize that we're communicating above their heads. And amongst us, we're just talking. We know what we're talking about. but we forget that we're so far removed from that individual that we don't understand that, that they don't actually understand. And again, as part of teaching, if the goal is to help people understand, the point isn't for me to demonstrate how amazing I am, right? It isn't to show that, oh, look at my slides, look at all this cool surgery that I do, right? It's sure, it's great, but you're teaching. So what is the goal of this? And so the AOs really kind of helped me with that. I became AO faculty a couple of years ago, and we really talk about, the delivery of education, right? It's really important. It's not about the content in isolation, but how you deliver that content is kind of really what makes a significant difference.
I agree with you. It took me a while to understand the indirect slash direct relationship between deltoid and syndesmosis and increased medial clear space, and how you can directly repair the syndesmosis and indirectly reapproximate the deltoid ligament. So I think that took me a very long time to understand. And once you understand, it makes a whole lot of sense, because I think the main issue that I see with students is that it's very easy to look at an x-ray and get so narrowly focused on bone that you forget that there's a lot of other things going on in there. And you say, well, like, I'd plate that and I'd put a screw in that. But you're understanding the dynamics that come from, in this example, an ankle fracture is going to be much more complex than looking at one joint on one view and saying, well, I'll put that back and then I'll plate it and then we're done. We go to lunch. Yeah, maybe, but understanding rotational components. And that's where I think trauma gets, there's multiple levels of trauma. There's the basic introductory understanding of anatomy, and you build upon that with reduction techniques, and then you build upon that with understanding hardware. Then you can advance it to understanding complicated things like indirect repair or specific reduction techniques for complicated fractures that don't just fall back into place. We've all been in surgeries where you look at the x-ray and you're like, oh, I'll pull on that. And then you get in there and you pull on it, it doesn't go anywhere. You're like, okay, well, now what? So it gets complex in a hurry. Not that other components of what we do don't get complex. Charco, reconstruction, all that stuff is very complex as well. But I'm with you. I love trauma. I love taking something, instant gratification. You can look at something that not walked, limped in.
Come to Philly, they're walking.
Crushed
They're walking
in.
still.
Okay, they limped in, and you put everything back together, and you start with this, and I can look, okay, and I put it all back together, and now look at this when they literally walk out of your office once they've healed. And so that instant gratification of putting things back together, I can get on board with. So what is your favorite surgery? If you had to pick, you said trauma, but what's your favorite? Is it ankle fractures? Is it calc? Is it something more complex? Liz Frank, what do you like?
My favorite surgery is a medial double.
Why?
Because again, it's kind of like a wow, kind of a eureka moment for me. I think, again, in training, we did traditional triples. And even if we didn't specifically address the CC joint, it was still a lateral incision. Right. So the conversation is always, hey, well, you're taking someone from valgus to rectus, you're stretching out that lateral wound, and et cetera, et cetera. And so the idea of just kind of really accessing the entire kind of medial column, particularly the two dominant joints through a medial incision, it's impressive to me how much work you can get done through an incision that's not that massive, right? Mm-hmm. Like it's kind of from the medial malleolus to kind of like, the medial cuneiform, right? And you can like really address someone's flat foot. You can even, and I routinely will do this, I'll sneak in kind of an internal brace. I'm sorry, I shouldn't be talking about industry stuff.
I don't care.
An IB just kind of to address the deltoid, because I've had issues where, again, when you go through that medial incision, you can bag potentially the deltoid ligamentous structures, and then you can kind of get that asymmetric valgus tilt in the talus, and then just hope that the rest of the reconstruction is aligned enough that you don't have an issue.
Yeah, the worst thing you can do is do a hindfoot arthrodesis and start to see progressive ankle valgus.
Oh, it sucks. It sucks because it was you.
Yeah.
Yeah. Like the foot was really flat. They didn't have ankle valgus. You go in there and you fix the flat foot. Now they have, it was you. Again, not necessarily that you messed something up, but like it started with you. You going in there disrupted whatever balance that had been achieved to kind of protect it. And so, yeah, I've been kind of protecting that deltoid since I've been doing it. But I'm just really impressed by how much work you can get there. And then again, even kind of really getting that forefoot pronated, you don't even have to specifically add kind of a medial column, an additional distal medial column, whether it's a lappy cotton, however you want to call it, to it. If you do it well enough. So it's an operation I love doing, and when you do it well, you can surprisingly do it relatively quickly.
Yeah. I don't mind if you mention industry. Every time you say something, they have to send me a check.
Right on. Yeah.
I wish that was true.
Awesome.
Yeah, medial double. I mean, sometimes I struggle to get to the very posterior lateral aspect of the subtalar joint or the very most lateral aspect of the TN. And so sometimes I'll cheat and just make a very small, not that big, CC, all encompassing lateral incision, but just a small incision laterally, especially now that I've started using MIS burrs to prep the joint. You can really kind of just make a very small incision and get in there and prep adjacently too. So I go back and forth, the isolated medial double arthrodesis versus also making an accessory lateral incision there.
I love a good open MP joint fusion too, man. I love a good lapidus. People ask me what's your favorite surgery, man. I just told you medial double. I love doing them. I can't tell you I love ankle fractures. I love so much,
Yeah.
Yeah.
When you fixate your double, mostly talking to kind of some of the younger people in there, what's your process for fixing that? So you're making a medial incision, you're going in, you're prepping the joint, and then what do? Are you pinning subtalar and then pinning TN? Are you fixating fully STJ? What's your stepwise approach?
Man, so I posed this question on that app, 15 Blades, to get a kind of different, because I've done them all. I feel like I'm happier with where I am now, but I first started with, varicing the calc initially and pinning the subtalar joint, and then I would go and I would adduct the forefoot and pronate it. Again, I know that with the TN joint pinned, I have less subtalar joint motion. And so that's kind of a thought process that I have now, probably more than I did before. I think if I don't get the TN joint in right, I think I don't have as much play in the subtalar joint as I would like. And so, even if I pin the subtalar joint first, I feel like I can still kind of manipulate the TN joint a little bit more. But I've kind of probably the past year, I've noticed a difference. Whereas, maybe doing the TN joint allows me a little bit more primary correction. So that's what I'm doing now. So, I genuinely am not sure whether it matters. Like reducing a talonavicular joint is almost like getting an orthotic nicely and contoured into the arch and stuff. So I think there's an art to it. So now I probably will do the TN joint, pin it, check the subtalar joint. If I'm not happy, back the wires out and try it in reverse. I don't try to commit too hard to that thought process.
Yeah, I agree with you. I pin subtalar, then I pin TN, and I check all the angles just to make sure everything is in good alignment. And if I don't like it, then nothing's permanent yet. Just back the wires out, readjust, fire the wires. You can make little micro adjustments as you go. I agree with you. So you mentioned the app 15 Blades. You and I are both on 15 Blades. So basically that's a way for anyone who has an NPI, I think, is who it's limited to. The residents and physicians to get on there and talk to each other, essentially, without the general public seeing anything and discussing things. So if you got a tricky case, you post it on there and people help you out and kind of recommend some things, and it's kind of private, hidden from the rest of the world. So I follow you on there and you post some really interesting, thought-provoking things. What are your thoughts on MIS surgery is kind of the buzz right now? I think we got bored with all the typical ways we were fixing everything. And now if you just say MIS in front of anything else, then it sounds cooler. You're like, MIS ingrown nail. Yeah, are you guys doing those? You're like, what? No, that's not a thing. But yeah, what are your thoughts on MIS and the role that it's kind of taking over everything everywhere you hear, including things that I'm doing?
Man, MIS is a philosophy. It's why people try to inject it into everything, because it's really it's an understanding of thinking of cosmeses, thinking of limiting the iatrogenic, insult. It's about joint, preserving joint mobility, So, I mean, when I think about MIS, I mean, we've been doing MIS outside of like technology. We've been doing MIS when we scope ankles, right? That's minimally invasive surgery, all right? And when you think about general surgeons doing laparoscopic surgery now and endoscopic surgery, a lot of that is all of that is MIS, because we understand that the body has it's a great capacity to heal. We can help it, and so I think the idea of just kind of limiting our footprint is, I think, is important. I think, philosophically, I don't get too weird, but it's sort of humbling, right? To kind of just step back and just kind of think about the audacity as physicians that we think we're going to go into an individual and just like strip open everything, because you'll only get better if I can see as much as I can and provide as much information. That's, let's pump our brakes a little bit and think about, a different way of maybe helping people. And I think that's why I think MIS is kind of taking off. An obvious kind of, duh moment is, particularly when it comes to kind of foot surgeries, people want their feet to look good, right? Like, doing a lapidus and you got a, 13 centimeter incision on top of the foot. I don't know if that's kind of what you want to kind of, I'm gonna trade my bunion for this scar instead, right? I think it's a good idea to kind of rethink how we do things. We think about microfracture now that we're learning is awful, right? And we've done it for a long time. So I think, it's changing your mind is a good thing. As you develop and you learn more things, it's growth, and so I'm a huge proponent of minimally invasive surgery, in all aspects. I mean, I think an obvious challenge, obviously, is we know that we are good minimally invasive surgeons because we were, previously open surgeons, right, in a lot of ways. And so we have this inherent understanding that helps inform that. And so it's always kind of that challenge when you're training residents, knowing what you know. But I think, again, I don't necessarily think we have to go back to the old way entirely. I think there are instances for it. But now that we know this way, how do we teach, kind of the up and comers kind of this different way and helping them understand what we know about anatomy without them necessarily kind of stripping people open and naked and looking at their bones in order that they think that they can actually, make a difference.
Yeah, it's kind of like the body will heal as long as I don't mess it up too much. Like as long as I don't do too much damage, things will heal. And if you think about it that way, as from a vascular standpoint, periosteum, tendon sheath, whatever structure you're operating on, if I do less damage, number one, the body has less healing to do because there's less things to heal. But number two, they're going to have less complications. If I strip everything open, there's no periosteum to the bone. Well, yeah, your non-union rate's going to go up. That makes sense, right? So utilizing small incisions. When you were talking, it kind of clicked in my brain that you and I might be the last generation that knows both open and MIS. And what makes us potentially better at MIS was the fact that we've done it open before. Aside from going to the cadaver lab, these students, residents, aren't going to have the experience of understanding what the inside of a first TMT joint looks like and how deep it is and how wide it is and what the curvature of the bone is. But you and I kind of have done enough lapiduses open that we understand what that looks like. So when I stick a burr in there, I can picture it in my brain. Okay, I know how deep it is and how, okay, I'm going to get to the plantar lateral aspect with the burr, and you understand that. And so it's an interesting thought that maybe these next generation, I'm sure they'll be great at MIS because that's all they'll do. But let's say the burr, the machine for the MIS burr breaks. Are they going to know how to convert to an open? Are they going to know how to do these other things? It's just interesting things to think about as we have this kind of generational shift from open to MIS. Are you a head procedure for bunions, or are you a lapidus guy?
So I love the lapidus, and I wrote a paper on it coming out about intracranial instability coming out of fellowship, and specifically as I referenced kind of those incisional concept, it was always for me something I struggled with, like kind of looking at that big giant incision on top of the foot. And then when I came out in practice, I turned it medially because I've done a medial double. So why can't I approach a lapidus through the medial side? I don't do as many MIS lapiduses. I do a mini open because I specifically want to plate it. And I specifically use the plantar lapidus plate, specifically, by Arthrex. I think our patients, again, when we talk about kind of early weight bearing, blah, 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 with lapidus, there's obviously not entirely standardized, right? I got colleagues who are walking people a week out. Some people wait almost a month, which is, well, is that really early weight bearing? I walk mine at about, well, let me back up and say, I allow mine to walk at about 4 weeks. I think they walk at at about 2 weeks.
Yeah.
And so again, when you think about, you mentioned understanding hardware as it relates to trauma, right? We know the kind of the benefits of kind of plating on tension sides, right? So if I know that someone's going to walk, my lapidus, I'm gonna put a plate kind of along the plantar, and it's really genuinely like a plantar plate. And I think people are uncomfortable with that specifically because of, again, familiarity, right? Most people do a lapidus from the top or the medial side. But I actually, since I've been doing this technique, I actually find it a little bit easier because I actually don't have to disturb the tibia tendon in any capacity. When I was plating medially, right, you got to resect it to open the joint, and then you got to mobilize the tendon until your plate's underneath the tendon, right? So you're fixating here and then pull the tendon back, and I don't have to do any of that with the plantar lapidus. So it wraps completely underneath the plantar aspect of the foot. So it actually makes my lapidus is a little bit quicker than it used to be. So at the base, lapidus. If I'm going to do anything other than that, I'm doing a Drado at the distal aspect with an MI spur.
Gotcha.
And then an MP joint fusion if it's something that's track bound or the individual can be non-weight bearing or what have you.
Yeah, people love those.
Yeah.
I will fuse anything. You come into my office, I will fuse anything that you put in front of me. They love it.
Yeah. So I feel like for a large part of my career that was true, and I think maybe as I'm seeing kind of people a little bit long term, I don't know if everyone loves it. So
as long as you put it in the right position,
no question.
You can mess that up in a hurry. You can get like IP joint contractures. You can get loss of range of motion at the IPJ. Then they have tough time propulsing off of the tip of their toe because of the IPJ pain or instability. I mean, they're not all sunshine and roses. I don't think any surgery is, but for the most part, it's because it was so bad in the first place that when they came into your office that they love it so much. If I just went down the street and started fusing people's big toe joints, they'd hate it. It'd be like, what is this? It used to move.
Yeah.
Right. But it's because it was so bad when they came into your office. It was so painful and arthritic and all locked up. That's why they love it so much.
Yeah.
Yeah, let's talk about kind of the transition in trauma to becoming more MIS. In terms of fibular nails, what are your thoughts on fibular nails versus open plating of a fibula? Let's just make it a relatively simple, non-comminuted, don't care Weber B, C, whatever, but what are your thoughts on nails versus open plating?
I mean, I think, again, from a technique standpoint, without question, my skills are better because I have opened many of them up and I've reduced many of them up. And so when I go to do nails, my radiographic parameters, I can get to them relatively easier. I can even make smaller incisions, wrap clamps around. I think fundamentally with MIS, there's always a cost consideration, right? I mean, the nails ain't cheap, even with bunion stuff, they're not cheap. But I mean, I think when you juxtapose, the cost to what you're getting kind of on the back end, maybe you can philosophically make an argument for it. I love them. I love the nails. I think they're great. Again, from a philosophy, from the standpoint of philosophy MIS, it's consistent. I think you have to be careful with comminuted fractures that you want to maintain length because those nails do obviously not that best a job of doing that. I think plates perform a little bit better. And so I like them. I'm not against them. I think you just have to be, you just got to be judicious and understand where you are because they ain't cheap.
Yeah. Pick the right patient. I agree with you. I did a test one time. I had 2 ankle fractures in one day. I nailed one and I did an open plate, and I was wondering if one would be faster than the other, but it was the exact same. I was like 19 minutes and then 21 minutes or something on like one versus the other. Obviously, you understand that the benefit of the nail is that they're small incisions and you're saving time on the closure on the back end. But I'm just so fast with a plate. I've done it so many hundreds and hundreds of times. Just get it in, get it on, get it out. And from a cost standpoint, you can make that argument as well. So
Of course.
understanding the correct patient to apply those things to, I think, is the most important part when it comes to that stuff. And I wonder sometimes if we're going too far in terms of like everything has to be MIS, and like what's the difference between a 2.5 centimeter incision versus 3 1 centimeter incisions. Really, it's just adding up to the same size incision. It's just 10 poke holes versus one big one. Like, what? I don't know. Sometimes I wonder if we were going too far in terms of MIS and trying to keep it small.
Well, Tom Rukas like objectively defined what an MIS incision is, right? And so it's 2 centimeters is the max, right? So 2.5 is like,
Yeah.
I'll accept it. I don't think 2.5. I think 2.5 is still MIS. I think again, the idea, I think, in my opinion, is compared to those incisions that were like the length of my hand.
Yeah.
Like even if your incision is a third the length, even if it's not small pokes, I think again, this is why I talked about arthroscopy. Obviously, those incisions are a little bit smaller, but like, even before like MIS instrumentation, I saw people doing MIS Austins, right? So, and then I have colleagues who do MIS, but without the technology that we have. They literally are using drills and, osteotomes and breaking it. And, you know what I mean? They're doing all that stuff. So, I think as with anything, there are a lot of different things to consider, but the philosophy still stands. And I think, it's a great thing, particularly when you think about bunions, even the idea of just sparing the joint and how the MP joint moves compared to open procedures. It's different, definitely different.
Yeah, for sure. So I thought it would be fun if you and I jumped into a few cases here and talked through our thought process on these. So what I did is I went back to residency. So I haven't seen these cases in 10 years. So there's no bias to them. And they were not performed by me. So we can be hypercritical. We can see how things have changed with time. We can kind of analyze them and kind of see if our thought process is aligned. So,
Jeff, I feel like you're setting me up. You're going to make me bash someone's x-rays and you're going to take them back to them and tell them that, listen, I told you your stuff was garbage.
Maybe I'll send this podcast right to them.
That's funny.
Honestly, I don't even remember who did any of these things. So, all right, first case, I'll just read it quick for anybody who's just listening. A 26-year-old female presents with left ankle pain, was dancing at a wedding. Sure imbibed a few beverages, slipped, twisted her ankle, unable to bear weight. She comes in with a pretty relatively common ankle fracture, medial malleolus. Hard to see if there's any comminution, lateral displacement of the talus, and then a pretty standard distal fibular fracture as well. So let's not talk like overly specific, but what are your thought process when you first see this? Obviously, you're thinking operative in nature. And then what are you thinking when you start working this up? Let's get a peek behind the curtain into the brain for anybody who's kind of learning this process.
Yeah. So, I think, agent activity matters to me. This is a Weber B fracture. So I know, equivocally that there may be some ligamentous instability component. It's also a short Weber B, and I always remember from training that these are great for, anti-glide plates, which biomechanically is just, excellent. And here you can actually see it. It would help kind of facilitate that reduction quite nicely. You got to be careful with that, though, because, depending on if there is syndesmotic instability, you have to address it. You don't have, type of that washer kind of laterally. So, you can do a lag screw and a plate with this as well if you wanted to. But the fact that she's relatively young, for me, makes me want to consider more kind of flexible ligamentous kind of reconstruction after I've done kind of the osseous work to kind of really see whether or not, that instead of static,
So what are your thoughts on an anti-glide plate? So we're putting that on the posterior aspect of the
Yeah.
fibula.
Yeah.
I'm trying to talk to all levels here, so just kind of simplify it as we go. So we're
I
putting the
got you.
anti-glide plate on the posterior aspect of the distal fibula. What are your thoughts on perineal irritation with a posterior anti-glide plate?
Yeah, so Weber and Strauss has actually looked at this and found kind of the position of the plate. If you were a little bit more lateral than directly posterior, the risk of the tendon being injured is lower. Traditionally the anti-glide plate also doesn't include distal screw fixation because the plate itself is supposed to kind of do the heavy lifting. Certainly, I think having distal fixation can help control any kind of rotational components to it. So I think you just have to kind of think about, plating it, particularly as you descend, kind of having a little bit more lateral than directly central.
And then what would you do for this? It's a relatively small medial malleolus fracture. It looks like it's mostly the anterior colliculus. I would guess based on what I see there with that shadowing on the remainder of the medial malleolus. But what would your fixation technique be for kind of a shallow medial malleolus fracture like that? Are you a screw person, or
I
are you
like.
worried about fracturing it and then you do a little hook plate? What are your thoughts on that?
I mean, you got to be ready for it, right? I mean, you have something tiny, you got to be ready for it. But I think you can be careful enough, and you can probably sneak like a 2.7. You don't have to compress it and over drill kind of that distal fragment to kind of bust it up. You can reduce it, clamp it, put a pin in. And if you do a positional screw, it's not the end of the world. Certainly, if you can kind of clamp it down and screw it down, it'd be great. It looks like kind of like an anterior collicular type fracture, so you can potentially even get like bicortical screw purchase and hit the back of the tibia with it, depending on how oblique you are.
Mm-hmm. So this is what honestly, I don't know. So we have a distal fibular plate with a bunch of non-locking screws, a lag screw, 2 screws in the medial malleolus with good reduction of the medial malleolus, and then a syndesmotic screw. So if we're being not even critical, because I think it looks good, let's not use the word critical. Let's say, what would you do differently with this? Because I can tell you what I do differently, but I want to know what you do differently.
Man, I gotta say, I think this looks pretty damn perfect.
Yeah.
I think if I am being a hair critical, maybe I can slide that. I think that plate's a hair lateral. This is actually one of the posterolateral plates I was actually thinking about. That there are plates that the distal end of it kind of descends and it's a little bit out of the way of the peroneal tendons. You could probably bring that syndesmotic screw a little bit lower, but kind of depending on the orientation of the medial malleus screws. If they're heading more posterior, then you can sneak your syndesmotic screw anterior to those.
Mm-hmm.
But my suspicion is that the individual probably ran into those screws, which again, it's not the end of the world. You got, tricortical fixation, it's fine. But I mean, I think this looks pretty good. I think that if we can get so this is AP, if you internally rotate a little bit more, you can kind of take a look at the gutter a little bit clearly, but I think this looks pretty money.
Yeah. So things I would do differently here. So I don't typically use non-locking screws in a plate. If a screw is going to back out and the head, if you put your finger down along the side of your lateral malleolus, your distal fibula, there's no meat that cover that. So if you get a headed screw that's sticking out above that plate, you can almost like read braille. I'm not saying that to like make fun of anyone or anything. I'm
No, I got
literally
you.
like, you can feel the bumps of the
Yeah.
screws for people that have these headed screws on their plate. So I use all locking screws because it sits down in the plate. I don't use a lag screw. I found that to be unnecessary. I don't use a syndesmotic screw. I use flexible fixation. But then the medial malleolus, I would use 1 or 2 screws like they did there. So some of that is just advancements with technology. Potentially they didn't have certain things available, or they have a different philosophy from when they were trained. So I think this is kind of interesting for us to not analyze how you or I would do it these days, but to look backwards and understand how people used to do it, or maybe this person still does it this way, because a lot of it depends on your training. Someone who's a 70-year-old orthopedic surgeon is probably going to fix every single ankle fracture they ever do the same way, because that's always how they've done it their entire career. So I may always do one the same way for my whole career, even though new things come along. So I think that it's well done. It's a well-aligned fracture, but interesting for us to think about. Next case, 19-year-old male presents for evaluation of left foot pain, was riding a dirt bike. The bike slid, fell over, crushed his foot. Lateral aspect of the left foot was hurting. ED revealed ED X-rays revealed left foot fracture. Put on a splint and followed up in clinic. So we have an AP and oblique of a comminuted fifth metatarsal base fracture that's intra-articular to the cuboid joint. So we have a significant amount of comminution, a little bit of displacement there, but impaction at the calcaneocuboid, or not calcaneocuboid, the fifth metatarsal cuboid junction. So what are your thoughts when you see this type of fracture?
Yeah, I mean, this is tough. I mean, this thing is it's intra-articular fracture. The risk of arthritis is, is elevated. There's no cure for arthritis, and the options for lateral column, particularly TMT, are just somewhat poor. So, the prognosis for something like this is guarded. I think you have to do your best to try and reconstruct and get the joint aligned, and then you have to probably put on like a mini rail to kind of give that joint some space, because any additional kind of undue pressure is going to kind of malalign that joint.
So why would you do the mini rail?
In addition to my RIF.
Yeah, what are you doing there? You're disimpacting, because that comminution is going to be difficult to maintain alignment with a plate alone, right? And so a mini rail is going to maintain that lateral column length and avoid that impaction that's going to occur at the fifth metatarsal cuboid junction. So if we think about what our treatment options are, plating and a mini column or a mini rail laterally. So this is the intraoperative image with some comminution of the fifth metatarsal base. Here it is with a mini rail, just like you said. What are your steps for putting on kind of a mini rail? Are you throwing your pins and then getting your distraction through where are you throwing your pins first?
Yeah, I mean, go back to the prior film if you don't mind. Yeah, I'll probably span here. I think you got to give yourself some room. I'll probably put one in the anterior calc, one in the cuboid, and then do the other two kind of the kind of distal segment of the met there, and just kind of really yank it out as best as you can. I would. I don't know if you have those distal, or whoever has the distal pins in the fifth or fourth met, but
fifth.
Yeah, you got to get in the fifth, because you got to kind of really, distract it really out. But I would probably put one of my pins in the cuboid, one in the calc, and just kind of, just stabilize that. That's what I would do.
Yeah. So if you were to just open this up and plate it without maintaining lateral column length, what do you anticipate would happen?
I think you're going to lose your fracture fragments, right? I mean, you got kind of this cuboid kind of pushing up on it, right? It's going to bust open. I don't think you're going to lose your alignment. The joint's not going to be reduced. So I think that's primarily what it's doing for you.
Yeah, so it's going to be incredibly difficult to maintain alignment of all your small comminuted fragments with plate and screw construct. A plate can sometimes maintain length, but only if the screws are through all of the fragments, which means on this image right here, there's that medial fragment that's going to be sitting there with maybe the tips of a couple screws in it, but you're not going to necessarily be able to maintain alignment of the entire lateral column. So putting that mini rail on there may not be the first thing that sometimes people think of, but it's important to disimpact that joint at the cuboid. For, like you said, if you do develop, he's only, I don't remember, 16, 19 years old. Yeah, he's going to be set up with fifth cuboid arthritis for the rest of his life. That's not fantastic. So how long would you leave the X-Fix on?
Man, I would leave this on all of 2 months, man.
Yeah.
Yeah. If assuming like I don't lose it, sometimes these things get all gunky and kind of Swiss cheesy and stuff, but I would probably go for 2 months if I can.
Yeah. And so you're maintaining that alignment. And then are you making these people take off the X-Fix in the office, or are you bringing them back to the OR?
Man, a 19-year-old kid. I mean, I'm considerate. I'm thoughtful. I mean, I've taken someone in the OR, and anesthesia was just like, go ahead. And I was like, I brought him to the OR so you can put him to sleep. Go ahead.
Yeah.
And I'm taking it off, and the guy's like, it's like crazy looking, Philly, I told you. So I really kind of pay attention to who the individual is. I think my default for a healthy, normal person, I'll take them to surgery, man. I don't need to torture them. They already been through enough.
Yeah. I took out a femoral pin one time in orthopedic clinic, literally with a screwdriver, not like a driver, like literally like a ratcheting driver. And I just said, hold on, buddy. And just went like, just backed
My
the pin right
goodness.
out. It's
My
like, all right,
goodness.
I just did what the attending told me to do. That guy was not very happy. Anyways, they removed the mini rail here, and that maintains some length. Hopefully, you're not going to make the risk of post-traumatic arthritis at that joint ever zero. But I think by maintaining a lot of that lateral column length, you were able to minimize that as much as possible. One final case here, 55-year-old male with a right heel pain. He went to the ED at an outside hospital, came in 5 days after original injury. He slipped down some wet stairs, fell approximately 5 feet, hit his right foot on the ground, had pain, bruising, swelling. Don't need to go through the entire physical exam. X-rays here are suspicious for a calcaneal fracture on this view. Obviously, we're going to get 3 views, so we're not just beholden to these 2 views and guessing. Here we can see the lateral cortical disruption at the inferior aspect of the calcaneus. When you look at the rest of the joint, though, it doesn't look bad. But anytime I see any type of suspicious findings, including any kind of cortical disruption of the calcaneus, concern for calcaneal fracture, I'm getting a CT scan. How about you?
100%.
Yeah. You can never go wrong with the CT scan. If you get a CT scan and it shows nothing, fine, who cares? But if you don't get a CT scan and there was something, well, now we got a problem.
Well, let me back up and actually not say 100%. I think there are those instances where, we have folks who, like, you have no plans on operating on them based on, whatever the situation is. And I think those outliers I'd probably avoid
Sure.
radiating.
So if we're looking here at the CT scan, we see some inferior cortical disruption of the calcaneus and then a lateral talar process fracture, which makes sense because of the mechanism of injury of the lateral talar process driving through the calcaneal tuber, causing the lateral talar process fracture and that split fracture through the anterior tuber of the calcaneus. But the posterior facet looks well aligned. When we get to this view, though, we start to see that fracture of the sustentaculum tali. So what are your thoughts when you see this? Because it's not terribly displaced. Are you going to let that fly, or you think that you can make that better with surgery?
I'm gonna let that fly. I don't think that alignment is too terrible, and honestly, with calcs, man, like the more of them you do them, calcs are tough, and the outcomes sometimes are not as satisfying as I think we hope for. And I mean, I think the overall alignment here is fairly reasonable. If this was my foot, I'm not having surgery on my foot.
Yeah, I would agree with you. If I got this CT scan on a 55-year-old male, we know the increased incidence of subtalar joint post-traumatic arthritis is high. Worst case scenario, we have some problems. We're going to do an isolated subtalar joint fusion at some point in the future, which even if I do surgery to try to realign this and make it better, it still doesn't negate the possibility of ending up with a primary subtalar joint fusion down the road. So I agree with you. This attending, again, I literally don't know who it is, decided to fix it with a mini open approach. So what are your thought processes for fixing a calcaneal fracture with either a mini open approach or the lateral extensile? What's your cutoff for having to do? Obviously, we'd rather try to avoid the lateral extensile incision if you can. It's fraught with complications, but sometimes you just can't avoid it based on the comminution or lateral wall blowout. What are your indications for choosing those 2 incisions?
Honestly, a big one for me is time of presentation. You said this guy showed up in your office in 5 days. I mean, best case scenario, like you're not getting the surgery for maybe another, 3 to 5 days. You already passed a week. When you're past about 5 days or so, the calcaneus gets really sticky and starts to heal really quickly. That it becomes really hard to kind of manipulate and reduce those fragments through small approaches.
Mm-hmm.
So I think for me, outside of comminution, whatever, I think timeline is major for me. People come in our ER, and if they have like an operative calc, we admit them and we try to get them fixed like pretty quickly through a sinus tarsi, assuming that the comminution is, the fracture fragment's amenable for that reduction. But I think time of presentation is huge for me.
Yeah, I think that's reasonable. So here they've pinned that inferior kind of split through the inferior cortex of the anterior calcaneus and then thrown 2 screws from P to A, and then thrown that wire from lateral to medial right into the sustentaculum tali. So that is an important view. That's something that we all establish as the constant fragment of a calcaneal fracture is the sustentaculum tali, called the constant fragment because it typically does not move. The rest of the calcaneus can move around, but because of the strong deltoid attachment to the sustentaculum tali, that fracture fragment typically goes unaffected in terms of displacement. So we're trying to repair everything to the sustentaculum tali. But good reduction there, good alignment there. I just wonder if it needed to be done. What do you think?
100%. I mean, beautiful work. And I think without question, you can potentially mobilize this individual sooner, move their joints and, do all these type of things a little bit sooner than you otherwise would if you treat them non-operatively. Again, this is my foot. I'm not having surgery on my foot on this.
Yeah, to me, all you've done is put in 3 screws that I'm going to have to potentially take back out if it ends up in a subtalar joint fusion. I don't know that what we did here with this surgery alleviated the risk of the interarticular nature and decreased the risk of post-traumatic arthritis. I just don't know that it had enough displacement to warrant that, but you never know. What are your thoughts there about the threads of the screw threads of the screw across the fracture there? Do you anticipate any issues with that? Not that there's a magical screw that would be able to get all the threads across unless maybe you went the other direction, but any issues with having threads across a fracture?
No, not the calcaneus. The calcaneal heals, pretty reliably. So
Yeah, so these are more kind of beams almost to structurally support the posterior facet and the sustentaculum tali. Like you said, maybe you're going to let them walk on it sooner, but you're basically beaming this construct through there to provide structural support rather than you don't even need any compression across the fracture. It's going to heal, like you said.
no doubt.
Anything else you'd like to touch on?
No, man. Thank you for having me. It was a great conversation. I didn't know what I was anticipating, but
I didn't either.
I put on my best underwear, and I think it went great.
Nice. I'm going to ask you one last question, and then we'll get you out of here.
No doubt.
All right, you've been out of residency now for quite a while. You and I are the old man playing the old man game these days. So, you have any career advice for any of the young people out there, either the young people who are interested in podiatry or the younger people who are progressing through the field? Anything that's kind of helped you get to where you are today?
Man, I think I'm fortunate to again kind of be in love with what I do. But I mean, I think you got to really, as with anything, just kind of really be intentional about kind of what you're trying to do. You got to write down your goals. You know, you got to put yourself around, the right people, however you do that, whether it's, listening to podcasts or commenting on people's like posts or what have you, right? Like, I think mentorship is really important because I think, despite our good intentions, I think we can misstep. And there are a lot of things that we don't know. There's so much about, money that many of us don't know about, not even just the general public's physicians. Like we're fortunate to kind of, be walking into careers that, certainly provide a better income than a lot of people. But it doesn't insulate you from the reality that you have to be responsible and plan ahead. And you're not an NBA superstar. You're not Steph Curry, right? You gotta actually do the right things with your money. And I think that's an important thing, whether it has to do with your loans or living within your means and buying cars. I think probably a huge piece of advice I would tell people is like, find a mentor, find someone doing the things that you would love to do, not because you are impressed by them necessarily, but because you genuinely kind of think about what life would look like for you, and you try to identify that these are the individuals that'll help me kind of get there. And it doesn't mean necessarily every person has to kind of look a certain way. People can drop jewels on you, drop gems in your life, and you don't know where they came from. So just kind of be open, enjoy the journey. You talk about kind of being cliche and being corny. Like, really enjoy the journey, because the journey is where it's at. You know what I mean? It's, we do all of these things that we talked about, right? Is just kind of a reflection of things that we've accomplished, right? And I think sometimes we forget that, and we work, and we don't kind of, smell our roses and just kind of understanding kind of our path in this process. But find a mentor, learn to kind of do the right things with your money, and just kind of enjoy the journey is the advice I would give. It's not going to, I don't mean to be morbid. It works differently for every single person. It does, the journey is not the same for every single person, but it's still a journey. It's still your own kind of life, So just enjoy the rock it out, and enjoy, make some memories, make some good ones if you can.
Absolutely. Well said, my friend. Well said. I appreciate you hopping on tonight.
No doubt, brother. Anytime, man.
All right. Thanks for joining me, Kwasi. So I'm Jeff Dikis, and this is Pod Patrol. We'll see you guys next time.
Take care, guys.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.